HR strips,
Hmm?
should, because we didn't go over categories, but we did go over
Right.
the work we were given.
Remember I said we would end where
Mhm.
we ended,
Okay.
right where we ended, which I'm going to try to remember right now.
Okay.
We ended at the summary slide. So yes, this is where we ended. So I'm going to pull it up right now so that we'll all be on.
Professor, I have a question too.
Okay. Go ahead, Jinhee.
Professor, can you hear me?
Yes. Mhm.
Okay, Professor, actually for this blood pressure, when mommy is while the contraction cycle, blood pressure for the vital sign,
Mhm. What
then
about it?
yeah, you say that when she's a really contraction, she's gonna be inflected with tons of blood, so it's not gonna be her real blood stuff. So I try to understand that you said that you gotta wait, and then I couldn't really 100% understand when I'm
So your
measure
connection is freezing up.
blood pressure.
Your connection is freezing up a bit, but I think maybe your question is, how do you, in practice, how do you do the blood pressure? Is that what you're asking?
How does it? Yes, Professor. Is it better here? Is it better here?
There, try it
Better
there.
here?
Is,
Okay. Yes, my
is your
question is about
okay, so is your question about the timing, like how you would do this blood pressure? When would you do it?
yeah, how for the
So
mother.
remember I said, right, you might have to, you put the cuff on, and then you might just have to wait until the contraction ends, and then you do it between the contractions.
So between the
You take the blood pressure
contraction,
between.
let me clarify. It's gonna be then resting time, or it's not right? Because
It will be during the resting interval, correct.
okay, that's what I want to make sure that like a resting interval. So between the contraction, the resting interval, that is the most. Okay, I got it. Professor, another thing that we did better heart rate. They have up and down. What is it? The average of better heart rate. Is there any formula, or you just estimate for the
Average for what? The fetal
better
heart rate?
Yeah, better heart
No,
rate.
I will never ask you I will never ask you the average. What I will ask you is the range. And you should be looking at a range.
So 110
right?
to 160.
Remember we said we wanted to see some variability. You want to see some variability. So you should be looking at a range. So 135 to 145.
Oh, so
Okay,
range is like what is the range?
A range.
So all the way bottom and all the way top, right?
Correct.
Okay, thank you so much.
Okay, you're welcome.
I'm sorry, Professor. I just wanted to clarify one thing because I wrote it in my notes and then I reread the chapter. So as far as moderate contractions, you had said that it feels like the tip of the nose, but in the book, it says that it feels like the chin and mild feels like the tip of the nose. So I don't want any confusion there. So which one?
You know, depending on which resource you're using, some might say mild, some might say moderate as far as switching those two. As long as you remember that the most intense will feel like your forehead.
Okay.
Okay.
Got it.
Before I forget, did anyone try to use Collaborate over the weekend?
I did, but I was the only one in there.
Yeah, me too.
But you were able to access it?
Yes.
Okay, I just want to make sure. I mean, I left it open for you guys to, you know, you could have done it. You can still use it. It'll be open this, you know, after class until tomorrow morning. So if you want to get together and discuss or whatever, you can sort out what time you'll be there. I'll leave that to you to figure out. Okay. Okay. Other questions? All right, I'm just going to grab my water and then off we go. Let me just talk about that. Mm, mm. Okay, so muscle tone and APGARs. I mean, if you think about it, neuromuscular there's a lot of overlap between the neurological system and the musculoskeletal system, but the muscle tone is not the same thing as reflex irritability. Okay, so just as so we left off at, we spoke about the different patterns. We spoke about early, we spoke about late, we looked at some strips. We talked about variable decelerations. And then we left off here at the summary strip. So so the exam will include everything up to this point. However, some things that I say going forward may help you tomorrow, okay? As I said, categories will not be on the exam because I did not cover them before the exam, but you will see them at some point.
I have one question.
Yes.
Just regarding the late decels, if you remember during clinical, we were discussing that, and I had said that no, those are early because they were just slightly off the peak, right? And you're like, oh, but they're not on that peak; they're late. But in FA Davis, I got that wrong because they were slightly off. But if it wasn't in the notably after, they were counting it as early and not late. So I just want to make sure that I'm thinking correctly tomorrow because now I got two different messages.
So the nadir will follow the peak. So the heart rate drops after the peak of the contraction.
Just follow that for the test is what you're saying.
After the peak of the contraction.
Okay.
So now let me just say, it's really weird when I'm on a different screen. It's kind of strange. Let me see if I can. There can be, in practice, sometimes there's a certain amount of subjectivity sometimes to strips, because sometimes, you might think, oh, well, it's a little bit ambiguous. Is it on this line or that line? Or, but I will try to make them very clear for you at this stage, okay? So,
thank you.
And again, you're welcome. As you can see, the heart rate, if it's dropping after the peak of the contraction, then it is considered late. Okay. All right. Any other questions before we? Okay. All right. So as I mentioned, what I'm saying from here forward will be on the Unit 2 exam. However, some of the information may help you tomorrow. Okay. All right. So in summary, basically a recap of where we left off. Early decelerations are caused by fetal head compression. They are consistent. They mirror the contractions. So remember, you have that kind of V on the fetal heart rate and a kind of slope up on the uterine contraction. So they don't require intervention. Continue monitoring your patient and document. Late decelerations are caused by uteroplacental insufficiency, and I gave you on the earlier slide some of the potential causes for that. We talked about some of the potential causes for that. So basically, the result is diminished oxygenation to the fetus. Late decelerations are a non-reassuring fetal heart pattern. Fetal heart, you might also see it written as a fetal heart tracing. And again, the fetal heart rate returns to the baseline after the contraction ends. Variable decelerations are as they sound. They are variable. They are variable. The duration, when they occur, how long they last may vary, and the intervention will depend on the depth and the duration of the deceleration. So a prolonged deceleration here for you to see. I haven't been in my office and there's just like all kinds of strange things happening on my desk. So how low does this fetal heart rate go? Are you comfortable with this? Is this alarming?
It's pretty drastic.
This should be pretty alarming. This goes on for quite some time. So this fetal heart rate starts at 150 and just drifts down. Okay, and so you have a good 1, 2, 3, 4 minutes before it starts to get back to anywhere near normal. So this should be very concerning, and you're always thinking about oxygenation, what's happening with oxygenation to the fetal brain. So significance of fetal heart patterns. Category 1 is a reassuring pattern. So these are your early decelerations. Category 3 are non-reassuring. Those are late decelerations. Category 2 are indeterminate. So they could go either way. You're not quite sure. You're still observing, maybe doing some intervention, seeing what's going to happen. So category 2, your variable decelerations may fall into category 2, but your variable decelerations can also fall into category 3. So I'd shown you some last week, very dramatic drops in fetal heart rate that were persistent, that were variable decelerations. Those might be considered a category 3. All right, so category 1, early. Category 3, late. Category 2, variable, but variables can also fall into category 3. And
Professor,
again, it's just, if you can just remember, 1 is reassuring, 2 is indeterminate, 3 is non-reassuring. The words are like as they sound, right? Like I said to you last week, reassuring, you're okay, you feel like, okay, this is going to be okay, this is going to be all right. Things are going in the direction we want them to. Non-reassuring, we're not going in the direction we want to go in, and indeterminate can go either way. You're going to continue watching really closely. So you have a patient that is a category 3, late deceleration. First of all, you want to make sure that what you're seeing is accurate. So clarification of the data, are the monitors in place the way they should be? You know, are we picking up artifacts? So I hope I'm alone. We tend to have mice in this building. So if you see me squeal and run out, you'll know there was a mouse. I'm not ashamed to tell you that. I have had it sitting right here and had mice running back and forth. So if that's the case, first of all, you want to make sure that what you think is happening is what's happening. And then you want to identify the cause. So why is this happening? Is it a lack of oxygen? Is it an hydration issue? Is it If this is a severe variable deceleration, do we need to really change her position? So what's going on? And then you're always seeking to improve fetal oxygenation. So reposition the mom, increase your circulating volume, promote oxygenation, okay? So it's the same things we've been talking about, all right? So just a little traffic light kind of thing about our categories, what's causing them, what you need to think about, all right? Probably more detail than you need, but sometimes having the green, yellow, and red are kind of give you a visual reminder. This is just another slide of the same, just looks more like a traffic light. Okay, so again, the essential components of the fetal heart tracing, you want to look at your baseline. So your baseline rate, which typically is going to be a range. So you want to see variability. Again, we always want to see variability. It should be present. I'm not going to expect you to analyze the exact type of variability, but you definitely want to see variability. Are there any accelerations? So the heart rate goes up. Are there decelerations? And if there are decelerations, what type of deceleration? And then are there any changes or trends over time? So is this a fetus that is having late decelerations every 3 minutes? Or is this a situation where you just saw there was just one late deceleration and then the fetus has been fine? So any trends, certainly any changes. So if anything is abnormal, we need to take action. And so intrauterine resuscitation is essentially what we've been talking about. So we don't have immediate access to the fetus. So when we see these patterns, we have to address them, but we're treating the fetus through the mom. So again, maximizing oxygenation by repositioning her, maximizing oxygenation by improving her circulatory volume, maximizing oxygenation by providing oxygen. All of those things are comprise intrauterine resuscitation.
Professor, I have a question. So
Yes.
as far as interpreting the slits, I mean, I know you said you don't want us to look, but let's say I see some decelerations, late decelerations. Some are okay, but I want to fix that problem. So how long will I be observing this strip? Is it 10 minutes? And as far as contractions too, am I looking at these strips for about 10 minutes and looking at these contractions for 10 minutes?
So it depends on what type of decelerations you're seeing, right? If you're seeing early, you're reassured and that's okay. You're just going to continue to monitor. Yeah. If you're seeing variable decelerations, you should be thinking the cord may be compressed, let me reposition them on. So ideally, you don't want to see any leak, you don't want to see any variables. Mm-hmm. Even though variables are a bit more common and are not always as alarming as late, you definitely don't want to see any late deceleration, okay? You definitely don't want to see any late deceleration. So again, if you see one late deceleration, you've been monitoring this patient, let's say since 7 o'clock, it's 2.5 hours. 2.5 hours? Yes, 2.5 hours. I can tell whether they changed the clock or not. 2.5 hours you've been monitoring this patient and there's one late deceleration. You will stand there and make sure that there isn't another, because that's a change to the previous trend. So it really, you have to think about it in comparison, in context of the patient, okay? Yeah, you have to think about it in context of the patient. If this is a patient that has been having variable decelerations and you're repositioning and then the decelerations resolve, then you can ease back a little bit. But I can't give you a time because it's always within context of what's going on with the patient. Okay.
Okay, thank you.
So again, think about how we're assessing. If we have external monitors, maybe this is a patient that needs an internal monitor, one or two internal, either the fetal monitor and or an IUPC to monitor the contractions. Interventions we've talked about. And then remember your evaluation. You're always completing your nursing process, which then takes you back to the beginning, right? So we started with the assessment, made a determination about what was happening, did our intervention. Now we need to evaluate. So going back and looking at that strip, continuing to look at the strip, are we still seeing variable decelerations? Maybe we need to reposition again, or maybe we need to give oxygen. What else do we need to do? Or you did all of your intrauterine resuscitation interventions, and now all you have are early deceleration, right? So this is the evaluation. That's what you wanted to see. And then you start back at assessment, okay? So always it is a loop, but you're never quite finished, right? You're always restarting again. So what do we have? Are we using the best method of assessment for this situation? What do we need to do? And has it gotten better? Okay, so questions up to this point. All right. I am going to give you, let's see, how long is it going to take me to get over there and get back? 30 seconds, all right? Everybody has a pen and a piece of paper? I hope. Yes? All right, 30 seconds. Start writing. Okay, done? So your 30 seconds are up. Whoops. Sorry, I had to wipe my mouse. All right, everybody's done?
Yep.
Okay, so just so that you can see how the contractions looking at one in relationship to the other, I don't know if this slide might not help. Actually, it might be more confusing than helpful. Let me see. This, I think I gave you as a handout just so that you can see the slides in relationship to contractions.
That's definitely a handout.
I'm sorry?
That's definitely a handout you give. The one you have on the screen right now.
This one?
Yes.
I did give or did not give? I didn't hear part.
You did, because that's why I looked at it this morning. I'm like, wait a second, that shows that late or that early deceleration just a tad late, like we did on Thursday. So.
Well, this one, the early.
The one before, that's slightly off the peak.
This one?
Yeah, I would consider that early, but in FA Davis, they marked me wrong for that.
Oh, because it's slightly shifted to the right.
Yeah.
It's like about there.
I marked it late, and they said it was early.
Yeah.
Yeah.
Yeah, In practice, to be honest, that a deceleration like this, you would actually wait for the next one so that you can make a better determination, because it is a little bit in between.
Yep.
Right? But this is not, going back to the question that Ruth asked me earlier, this is not a patient that you would easily walk away from, because you don't really know what's going on with this patient. So this is certainly a patient that you would monitor closely to see what is this really? Are these going to define themselves as earlies or as lates?
And just to be clear on the early D cells, like the one that's there, that's totally fine. That's like a reassuring pattern. It's not too deep. There's nothing crazy going on, right? So just because it's a deceleration doesn't make it non-reassuring. Like the earlies can actually be reassuring.
Right.
Okay.
The earlies are reassuring. The earlies are, if you have to see anything, the earlies are what you want to see. Yeah.
Thank you.
So any other questions? Okay. All right. So it wasn't a lot more, but I think we had gone, if I remember correctly, we had gone a little bit overtime on Tuesday. So this is the little end piece to unit 1. So yay, all of you, you survived. So no variable.
Not yet.
I'm sorry.
Surviving is tomorrow. We got through it. Yes.
Yeah. Tomorrow will just let you know how well you survived it.
I hope so.
Well. So typically we don't see variable and late deceleration together, but let's say you have a mom that, I think if I understand correctly, you're asking if you have a mom that's in labor, you look at her strip and you see some variable and some late, like mixed in, there's something really going on there, right? And that you really need to pay attention to that. Now, again, the question is, are the monitors in place accurately? So you might need to do your Leopold's again, make sure that the monitors are picking up accurately. If you're still getting the same, this is a patient that might need internal monitoring. Okay, but something's definitely not right if you're seeing both. Hi, thin spikes, they might be fetal movement. You're talking about accelerations, right, Simona? I don't know where you are. There you are. Okay. So typically those are okay. All right. Okay. So on to postpartum. So there are some things in our.
So are you doing postpartum physical or postpartum?
So there are some things in postpartum that we have talked a little bit about, that I've alluded to. There are some things that we have not discussed at all. So as we go through, I'll hopefully clarify those. Okay. We're not moving. Okay. All right. So, matter of fact, let me go back. So we are entering what might be referred to as the 4th trimester here, the postpartum period. Again, the initial recovery period begins right after the 3rd stage, when the placenta is delivered, and your main focus is homeostasis and to prevent postpartum hemorrhage. All right. So changes begin with involution of the uterus. So you certainly do want to see involution of the uterus. And what causes it are the contraction of the muscle fibers. So you want the muscle fibers to contract around the blood vessels, because again, that is what is going to stop the blood vessels from bleeding. So you want to see contraction of the muscle fibers around the blood vessels. There will be some breakdown of tissue and then regeneration of the uterine endometrium. I don't know why I can't.
Question, just on the contractions here. I think from FA Davis, I saw that oxytocin is given at this point to help with this. Is that true or no?
So I'll talk about that. I'll get to oxytocin. I'm talking about what the body does on its own initially, and then we'll talk about the pharmacologic assistance after, but what the body is doing on its own. So contraction of the muscle fibers, I've already said that one of the important assessments, and I'm going to talk more about this today, is making sure that the uterus is contracted. And again, this is why, because you want to make sure that the muscle fibers are contracting around the blood vessels. So catabolism, there is going to be some breakdown now. You'll have some breakdown of excessive tissue, shedding of the endometrial lining. So all of that contributes to the involution, and all of those are part of the involution process that happens with the uterus. Okay. The uterus, the involution process takes somewhere between 6 to 8 weeks. And the uterus will rapidly decrease in size over that time. So, descent of the fundus. Descent of the fundus. All right, so immediately after the delivery. So again, I'm just going to say this once and I expect you to remember it. You want the uterus to remain firmly contracted throughout. Okay, so I won't keep saying that, but you want it to remain firmly contracted. So immediately after the delivery, the fundus is either at the umbilicus or somewhere between the umbilicus and the symphysis pubis. So immediately after the delivery, so remember where we started, okay? The process of it ascending up as the fetus grew and then lowering with lightening. But immediately after the delivery, it's usually at the level of the umbilicus, maybe slightly below, somewhere between the umbilicus and the symphysis pubis. And then the somewhat, what can be a little bit hard to kind of wrap your brain around is that it actually ascends, it actually goes up about 1 cm, about 12 hours after the delivery. It goes up 1 cm, and then it begins to descend. Okay, so initially at the level of the umbilicus or slightly below, then it goes up about 12 hours after, and then it starts to descend. So what you are really assessing, you want to make sure that immediately after the delivery, where it should be at the umbilicus or slightly below, and then basically what you're going to see is a descent of 1 cm or 1 finger's breadth, the width of 1 finger per day. So it should be descending approximately 1 cm every 24 hours. After 14 days, the uterus should be back in the pelvic cavity and should not be palpable. Should not be palpable. Okay, when you, I think there's another picture, and there's actually a nice picture in your book. When you are assessing the fundal height, it is always a two-handed procedure, always a two-handed procedure. One hand, the hand that is above the symphysis pubis on the kind of the suprapubic area, that hand, so in this case, this hand is stabilizing, okay, is stabilizing the uterus. And then the other hand is actually doing the assessment. Always with two hands, one to stabilize, because the muscle is, remember, this is now a hollow, it's a hollow muscle. This is a muscle that was filled and is now hollow. And we'll talk about this when we get to unit 3, but without stabilization, there is the risk that with manipulation, the muscle can invert and basically turn inside out. So you always want to have one hand stabilizing the lower end of the muscle to prevent that, okay? So always a two-handed procedure. When you are assessing the uterus, you are assessing 3 things. Whether or not it's firm, is it firm or is it boggy? Boggy being soft, okay, which means it's not contracted. So is it firm? The level of the fundus in relationship to the umbilicus. And you are assessing whether or not it is midline. Good morning. I'm well, thank you. How are you? Okay, so 3 assessments. Always, every single time you assess, you're checking for 3 things.
Professor, what was the third one? First one is a firm. Second is a level of a fundus with a umbilicus. And third one was
Midline.
what?
Midline. Whether or not it is midline. And I'm going to talk more about that, but I want you to remember that always, always 3 things. When you're assessing, you are also checking what the lochial flow is, and what I'm going to talk about lochia in just a minute, all right? Now, it's important to look at that and to also notice that as you are assessing, because when you're doing this to assess the level, you are putting some amount of pressure on it. And so you definitely want to assess to see if the assessment process results in an increase in lochial flow or any passage of clots.
Can you say that one more time, please? Or type it. I'm not getting the type of flow you're saying.
I'm sorry, I didn't hear your question, Fred.
Are you saying motile flow, like M-O-T-I-L-E?
No, L-O-C-H-I, lochia, L-O-C-H-I-A.
Got it.
I'm sorry, Professor. So you said after doing this
I had to
assessment,
turn it up and I turned it off. Okay. All right.
so I'm sorry, Professor, after doing this assessment, that's expected, right? So that's the lochia, that's normal. You want that after doing this assessment to the uterus.
No, what I'm saying is you're doing, every time you do the uterine assessment, you're checking for those 3 things. While you're doing it, you're also keeping an eye on the lochia. So because you doing this assessment requires some pressure, you want to see if it results in an increase in lochial flow or the passage of any clots.
Okay, so you want to note that. That's important.
You want to take note of
Okay.
that. Yeah. Mhm. So again, basically the width of one finger is about 1 cm. So we're using our hands to do the measurements. So you're paying attention to how many finger breadths below or above. Ideally, it should be below, but if it's not contracting the way it should, the fundus may be above the umbilicus, but you want to pay attention to how many finger breadths, because then that's going to tell you how many cms below, okay? So again, the hand that's over the suprapubic area is the stabilizing hand, so stabilizing the lower end of the uterus, and then this is the hand that is actually doing the assessment. Okay, I'll come back to after pains, but since I'm here, I'll just talk about lochia. So this shedding of the endometrial lining, the catabolic process, and the bleeding, all of this is what lochia is, okay? So lochia is this post-birth, post-delivery uterine discharge. It contains blood, contains mucus, it contains uterine tissue. Again, the catabolism is the breakdown of tissue, right? So that's what it contains. So there are 3 types of lochia. Initially, for the first 3 days, you will see my chat box for some reason refuses to open here. So I have the types of lochia on another slide, but initially it is lochia rubra, R-U-B-R-A, R-U-B-R-A. That is what you see for the first 3 days. It's deep red in color, bloody with some mucus in it, like a darker red, not a bright red, but a darker red. And I'm going to talk about this as we go forward, because you have to begin to distinguish what is lochia from what might be bleeding from a laceration. All right, so lochia is going to be a little bit darker red, has a little bit more mucus in it. You may see small clots initially. There may be some smaller clots initially. So that's what you expect to see the first 3 days. So certainly, while most patients are with us in the hospital, we will see lochia rubra. Lochia serosa, S-E-R-O-S-A, serosa, is more pinkish in color. Sometimes it's a little bit brownish. It's generally has a more serosanguinous consistency. And we usually see that day 4 through day 10. So day 4 through day 10, lochia serosa, pinkish, brownish, serosanguinous in consistency. And then lochia alba, A-L-B-A, is yellowish in color. And it kind of goes from yellowish to like cream color to maybe a more whitish to clear. It's along that kind of continuum. So this is as the process is kind of wrapping up, so to speak. And that might last from we usually see that from day 10, day 10, day 11, when the serosa kind of, it transitions into lochia alba. And then we'll see that for maybe sometimes 4 weeks postpartum. And then it kind of diminishes to clear to the typical vaginal discharge, vaginal secretions, all right? So regardless of the type, lochia should not be malodorous. Should not be malodorous. I've said this before, like with any bodily fluid, malodorous tells you you're dealing with infection, okay? Might have like a fleshy odor, but it should not be malodorous. All right, so where you would be concerned is if you see excessive spurting. First of all, if there's spurting of bright red blood, that is a laceration. That's frank bleeding. So I want you to think about, like, let's say if you are chopping vegetables or something and you cut your finger, that bright red blood, that's what you would see if there's a laceration. That is not lochia. Lochia is a darker red than that. Bright red tells you laceration. So you should be thinking either cervical laceration or vaginal laceration. Remember, the area is very, very vascular. Remember what I've said about pushing against a cervix that is not fully dilated or effaced, that could cause a cervical laceration. And I'm going to talk more about lacerations, okay? So bright red, you should be thinking laceration. You should be concerned if you see large clots. If it's one large clot, okay. But if you're seeing numerous large clots, heavy flow of lochia, you should be concerned that you are on your way to hemorrhage. Malodorous lochia, as I mentioned, you should be thinking infection. If lochia rubra persists beyond postpartum day number 3, so that's postpartum day number 3. As I said, you see lochia rubra day 0, delivery through postpartum day 3. That is concerning. If the lochia serosa is ongoing beyond day 10, that is concerning as well. Any time the lochia flow exceeds how many days, or a patient that, let's say, has 3 days of rubra, and then this is, say, day 5. So she's having lochia serosa and then rubra begins again. We're going backwards. That is concerning, okay? And that tells you that we're dealing with a hemorrhagic process. So you want to keep track of the type and the days. And again, this is important to our patient teaching. So in general, NSVD patients are hospitalized for 48 hours from the time of delivery, 48 hours from the time of delivery. C-section patients, 72 hours from the time of delivery. So if you think about it, when these patients go home, they should be having lochia rubra, but you need to make sure that you're teaching them what they are self-monitoring for, that they should advance to lochia serosa and then to alba, what the time frames are like, how to monitor the amounts, at what point they might need to be seen, okay, by their provider, whether or not they have an appointment, at what point they need to be seen. So the amounts of lochia, it's difficult to quantify. So what we tend to teach patients to do is to look at the saturation of the perineal pads. So how saturated the perineal pads are, whether it's scant or light, moderate, or heavy saturated. So most references will say to be concerned about a saturated pad. If a pad is saturated within 15 minutes or less. What I practice and what I teach is that you need to pay attention. If a patient is saturating a pad within 1 hour, that should be a red flag for you. You never want to wait until the patient is well into an established hemorrhage. We have to see the signs coming and respond before, okay? So if the patient is saturating a PeriPad in an hour, your red flag should be up that this patient more than likely is on her way into postpartum hemorrhage. So let's say you do have that. You have a patient, I'm going to ask you to put it in the chat box. What you have a patient that is saturating, let's say she delivered during the night. Let's say she delivered about 4 in the morning, and you're taking care of her now on the day shift, and she is saturating a pad within an hour. She saturated a pad within 50 minutes. Let's say this was a pad that was put on at 9:30 and it's almost 10 after 10 and the pad is saturated. What's your thought? What, in as few words as possible, what are you thinking? I know you're thinking hemorrhage, but be a little bit more specific about that. What are you thinking? And so I'll ask you to put it in the chat box. Okay, so no, postpartum patients are not allowed to use tampons. So typically not for about 6 to 8 weeks, not during the postpartum period. So yes, there may be placental fragments left inside. The uterus more than likely is not contracting the way it should. You more than likely saturation, you're not going to have that from infection. Rupture of incision. Fred, which incision were you thinking?
Cesarean.
But if the cesarean incision has ruptured, that might lead to bleeding at the incision site, but not necessarily lochial, an increase in lochial flow. Okay. Rupture of blood vessel in the perineum. So a rupture of the blood vessel in the perineum. So Sarah, what were you thinking? Where in the perineum? Let's see if I can find you. Sarah, you said a rupture of blood vessel in the perineum?
Yeah.
What were you?
Around the birth canal.
So that might result in actually in bleeding into the soft tissues. So were you thinking like, I'm trying to figure out where the blood vessel you're thinking of. You're thinking within the perineal tissues?
Yeah.
So, okay. So if there is bleeding within the tissues, anytime there's bleeding within the tissues, more than likely that's going to lead to a hematoma. So the blood flow would not necessarily come out of the vagina, it would be into the tissues. Okay. All right. So you have a patient that's thinking that you're thinking is hemorrhaging, possibly due to either retained placental fragments, the uterus is not contracting. What's your um mm, mm, mm. Okay, what are some of the assessments you're going to do now? You don't know which one it is, but what are some of the assessments you're going to do? Not just you, I mean, I'm asking everyone. What are some of the assessments you're going to do?
I mean, I would go straight to the vitals and blood pressure and see how that's being affected.
So you have to check your vitals. You have to check your vitals. So you definitely want to see whether or not the uterus is in fact firm. You want to see the level in relationship to the umbilicus, and you want to make sure that it's midline. Now, the reason that it's important to make sure that it is midline is if the bladder is full, the bladder is going to prevent the uterus from involuting. So we've been talking about this troublesome bladder, it seems like for a couple of weeks, right? Remember we talked about how a full bladder can prevent fetal descent. A full bladder can also prevent the uterus from involuting. So you want to make sure that the bladder is empty. That has to be a part of your assessment as well. And if that's the reason that you're checking to see if the uterus is midline. All right. Okay, that's basically that. After pains. After pains are the uterus, remember, is contracting back into the size and shape that it was pre-pregnancy. In a multiparous woman, a woman who has had babies previously, the uterine muscle has been stretched and has returned to its pre-pregnancy size, and now has been stretched again. So after pains are actually that pain of the uterus contracting back into size and shape. After pains are going to be more pronounced in women who are multiparous because the muscle has been stretched, retracted, stretched, retracted. After a few times, it takes more for that muscle to contract itself back, okay? So multiparous are going to have more after pains than primiparous. Okay, the cervix. So immediately after the delivery, the cervix is somewhat flabby and it's still open. So remember, the risk of infection, everything is still open here, okay? So there's a risk for infection. The cervix may be edematous. There's the possibility that there are small lacerations. So again, another reason to pay attention to the lochia, because you might have a normal amount of lochia, the dark red, and then you're seeing mixed in with that some bright red bleeding. If you're seeing that, you should be thinking there's a laceration somewhere, okay? The dark red is normal, but that bright red shouldn't be happening. Where is that coming from? So the cervix, although it's flabby initially, after the delivery, it does heal rapidly. Within a couple of days, it resumes its normal shape, becomes firm again, and the os will close. But typically, after a vaginal delivery, the shape of the os changes from circular to more of a slash type. It looks more like a line than like a little circle, okay? So the channel changes, the shape definitely changes. So the vaginal walls have been stretched during the birthing process. And sometimes that is apparent. They may appear edematous. Again, there may be small lacerations. The folds may not be as present initially because of the stretching, and then the folds will gradually be able to be seen over the weeks as the vaginal wall heals. So patients who usually sexual activity is not encouraged until at least 6 weeks post-delivery, we recommend that patients be cleared by their provider to make sure that everything is healed and so on before resuming sexual activity. But initially, some women will complain about discomfort during sexual intercourse because of the changes in the folds and in the walls of the vagina, and also as the body is kind of reacclimating in terms of hormones and so on. So the perineum, the pelvic floor muscles stretch, thin, and weaken with childbirth. It can take a little time for those muscles to regain their tone. They may be edematous, they may be reddened, erythematous. Excuse me. So it's important to assess for lacerations to the perineum. And we'll talk about the degrees of lacerations. I'll get to that. If there is an episiotomy, that needs to be assessed. Assess for hematomas to the perineum. And while you're doing these assessments, I usually recommend just assess for hemorrhoids as well, because you're already there. Instead of, completing that and then going back, you might as well assess for hemorrhoids as well while you're there, even though it doesn't really have to do with the, it's a different body system, but still. Relief of perineal comfort. So first 24 hours, cold is recommended. So ice packs to the perineum. So you want to diminish the swelling. So first 24 hours, cold, thereafter, warm. So first 24 hours, ice packs. After the first 24 hours, warm sitz baths can be used.
Professor, is there any reason that why first the 24 is ice pack and then after 24 is warm?
Because remember, you're preventing swelling. To prevent swelling, so that is why the ice will diminish the swelling. So in the first 24 hours, ice, and then thereafter warm. Okay.
Thank you.
All right. So teaching self-care measures. So some of the things that we need to teach are about changing the changing peri pads. So peri pads should be changed, of course, when they need to be changed, but also after a void, after a bowel movement, wiping from front to back. So the usual kind of hygiene that you would that you would teach, but also because the perineal muscles have been stretched and weakened, you want to teach even everyday kind of your ADLs, your everyday activities in a way that supports the muscles. So I'm going to ask all of you, I think everyone is sitting, so I'm going to ask you all to stand up for a minute, just for a second. It'll only take a second. So stand up. And I'm going to stand up as well. So stand up, and when you sit down, I just want you to pay attention to your to your perineum and to your gluteal muscles. Okay, all right. So everyone, just sit down as you normally would. No big deal, but just think about, feel the muscle, what you do. Okay. All right. So now I want you to stand up again. I know, and what is she doing? So stand up again. And this time when you sit down, I want you to actually clench your glutes and tighten your perineum, but do it before you sit, all right? So clench your glutes, tighten your perineum. It's a little bit awkward, and then sit down. So you might not, hopefully you can feel there's a difference there. There is a difference. So if your perineal muscles have been stretched, that is what you want to teach your patients to do, because it supports the area so that when they're sitting, it doesn't, the muscles don't splay as much. You already have weakened, stretched muscles. If they just sit down, the muscles will be further splayed. What you want to do is support them, okay? All right. That's our exercise for the day. Evaluate them. So endocrine system changes. This is where we left off. So this is where I will resume. So ovulation, menstruation will resume within 6 to 8 weeks. Every body is different. So there can be some variations there. If she is breastfeeding, that will delay the return of the ovulation and menstrual cycle. Lactation and I'm going to leave that, and when we talk about newborn nutrition, I think it'll just be more suited there. What I will say is during lactation, when the mom is breastfeeding will stimulate the release of oxytocin, and oxytocin is going to cause the uterus to contract, which you want, right? But in the multiparous mom, those contractions can be painful. So she might complain about the after pains. You have a mom that, let's say she's G6 or G7, she's going to have some after pains because that uterus has been stretched multiple times. So it's going to take more of a contraction effort to get that uterus back together. So she might need a little ibuprofen or some pain management before she starts breastfeeding so that she can be comfortable while she's doing her breastfeeding.
Professor, is that why also after the baby is born, they encourage breastfeeding right away to help with
Well,
the
breastfeeding, well, think about it. What do you want to happen right when
contraction?
the baby is born?
Oh, you want the placenta to come out and you want contractions to occur. And if breastfeeding releases oxytocin, that's good.
Why do you want those initial uterine contractions right after delivery?
To prevent hemorrhage.
To prevent hemorrhage. To prevent hemorrhage. Right. So you actually encourage a mom to breastfeed right after. You're working with the body's natural process to prevent hemorrhage. Yeah, so that is why. Andres, you had a question?
Oh, no, not at all.
I had a question, Professor. I'm sorry, but I didn't follow how the breastfeeding was linked to the pain management in the uterus.
So you understand, though, that the uterus needs to contract to get back into place, right?
Yes, and it's more
And-
painful in multiparous moms.
Right. So oxytocin is what causes those contractions. So if you have a mom that is breastfeeding while she's breastfeeding, because of the hormonal loop, oxytocin is going to be released while she's breastfeeding. And so the uterus is going to be contracting. She's going to have after pains while she's breastfeeding. So a multiparous mom is going to be uncomfortable while she's breastfeeding. So you might need to consider what you're doing for pain management before she starts breastfeeding so that she can be comfortable while she's breastfeeding. Okay? Let's see. The only thing, oh yes, let me mention this right now. Going back to ovulation. So remember, there are hormonal fluctuations that are occurring right now. And so due to these hormonal fluctuations, ovulation can occur without menstruation. And so that is an important part of our teaching, because if this patient is sexually active and not using contraception, she can become pregnant fairly early after delivering this baby, okay? And so I have seen patients come back at that 8-week postpartum visit and they're pregnant. But the menstruation has not resumed as yet, but they have ovulated, all right? So that has to be very, very clearly explained. I don't know why this chat box will not open. Weight loss. During the birth process, 10 to 13 pounds are lost, 5 to 8 during the early postpartum period, and then the adipose tissue is lost a little bit more slowly. So just a reminder of what all of that weight was. So as I mentioned, we no longer need all of that fluid volume and the excess body fluid. The uterus is now shedding, so and shrinking. So we don't need all of that. We don't have the amniotic fluid. We don't have the baby. We don't have the placenta. So a lot of the weight immediately is lost right after, just as part of the birth process. Okay. Immune system, we've talked so much about rubella. I know that you know this, the whole story with rubella already, what you need to do. Hepatitis. If a mom is hepatitis positive when the baby is born, and I will mention this again next week when we talk about newborns, but I want you to make a note of this. Mom is Hep B positive, that baby is going to need the Hep B vaccine and hepatitis B immunoglobulin within the first 12 hours of life. Okay? So mom is Hep B positive, hepatitis B positive. We need to make sure that baby has the hepatitis B vaccine and the hepatitis B immunoglobulin within 12 hours of life. All right. Both of those are IM injections. And as I said, we'll talk a little bit more about that next week. RhoGAM, we've been mentioning off and on, just a reminder, all Rh negative moms who have babies that are Rh positive should be given RhoGAM within 72 hours of delivery. We want to suppress antibody formation in the mom. All right.
Professor, I have a question about the rubella. So if the mom was negative, you will advise to have the vaccine after the birth, but she can refuse, right? It's not
We can always,
not
we
obliged.
can refuse.
Yeah, okay.
Mhm.
Okay.
We can refuse. Okay, so our postpartum assessment and care. So now you know, you have an idea of all of the changes that are happening. So now let's talk a little bit more really about your assessment. So you're going to have your initial assessment. You walk into the room, you know, you kind of eyeball quick initial and focus assessment. We're going to talk a little bit more about what you're doing there. But I want to remind you, always, always, always chart review. So I impressed upon you the importance of knowing the patient's history. So knowing her parity, the way a G1 is going to experience postpartum is very different from a G5. Some of the concerns are going to be different. So you need to know the parity. What is the date, time, and type of delivery? So what is the importance to the date and time of the delivery as far as your main assessment? So first of all, what is your main concern? What's your main concern with this postpartum patient?
The uterus coming back.
I want you to, so yes and no, but what's your main concern? I want you to reframe that into a concern. You don't want this patient to what?
Hemorrhage.
To hemorrhage. So postpartum hemorrhage is your main concern. Now, how does that relate to the date and time of delivery?
It increases. It's a high increase an hour after delivery, and then you have to continuously assess. And then you have to make sure that the uterus is contracting, because if it's not, that's not good. You don't want that, because then you know there's a higher risk.
How does that relate to the date and the time? So yes, there's a risk of, there's somewhat of an increased risk of hemorrhage immediately after, but how does this relate to the date and time? And how does that relate to what you need to do?
The early in the morning is the lowest pulse rate, something like that's related.
Because based on
remember,
anything, you have a number of.
What did I say to you here?
The centimeter, yeah.
Remember what I said to you. You need to know the date and time of the delivery so you know where you expect the fundal height to be. Okay? Where you expect the fundal height to be on day 1 is not where you expect it to be on day 3. On day 3, you expect it to be lower. But you need to know the date and the time of the delivery so you have a point of reference. Okay? So when you go in to assess the mom, you already know she's day 3. I expect her fundal height to be 3 cms below the level of the umbilicus. as opposed to a mom that's 12 hours out or 24 hours out. Okay? So,
Quick question, just on that. You said during the first 12 hours, it might go up a centimeter,
it might go up.
and then it starts to go down from there. So in the first 24 hours, you're still expecting
It goes up, and
Yeah.
then every 24 hours, you're looking at a 1 cm descent.
Okay, so it's not like it goes up and then 12 hours later it's down. It's 24 hours from that up, or is it just every 24 hours you still expect?
It's basically every 24 hours. It goes up about 12 hours, and then it'll start to descend. Yeah. And so you're looking at, I mean, you know, and then it's basically 1 cm every 24 hours. Okay. But again, you need your reference point to know, is this what I expect or what I don't expect? Okay. All right. So date, time, type of delivery, whether she delivered vaginally or cesarean, the uterus has to involute, and you are expecting the same rate, pace of involution. So I realize that you're probably cringing. We might not have enough time to go through everything I wanted to talk about C-section patients, but you might think, oh my gosh, I don't want to do this bundle assessment over this C-section incision. You have to do it. So it will be uncomfortable. It might be more uncomfortable for you than the patient. Because typically what I find is students are always cringing about having to put pressure on that near that incision line. But you need to know whether or not this patient is involuting. Is she at risk for hemorrhage or not? It's got to be done, okay? So regardless of the type of delivery, that has to be done. But you need to know whether or not she was a section or vaginal delivery, because that's going to influence some of the other assessments that you will do. So did she have an episiotomy or not? Did she have any lacerations? If she had lacerations, are they first degree, second degree, third degree, fourth degree? We'll talk about those tomorrow. Anesthesia. Was anesthesia used? What type of anesthesia was used? Did she have any significant history? Was she hypertensive? Is she hypertensive? Is she diabetic? Is she, you know, all of those sorts of things. Was she on any medications, any allergies? What is her chosen method of feeding? And where is the baby? So please do not forget the psychosocial part of this. Where is the baby? Do not make the assumption that the baby's in the nursery. The baby may be in the NICU because maybe the baby had an issue with breathing upon delivery, okay? And so when you walk into the room and see her crying, you need to know that before you go in, so you know how to approach her and what her concerns might be. So you're ready to answer her questions and to meet her concerns, all right? So location and status of the baby is important to know. Okay, so vital signs, postpartum vital signs after a vaginal delivery. Whether vaginal or section, you're always going to follow the facility policy. So whatever the facility says, that's really what you're going to do. But to give you some parameters of what's typically done, 15 minutes, Q 15 minutes for the first hour, and then Q 30 minutes for the second hour, and then Q4, and then Q8. So assuming that your patient is stable, a C-section patient is going to be in the recovery room. And so we'll be getting Q15 minute vital signs for some time. So depending on how the patient is recovering, then those will become 30 minutes, 1 hour, 2 hours, and so on.
Professor, a question. Since it's a C-section is a post-op, the first changing and check of the incision is due at the surgeon to perform, right? Or in this case, we are
Change of what?
as a post-op, as a post-op, is the surgeon who's gonna check the incision the first time or to change?
So the first dressing change,
Yes.
it is the surgeon. And we'll talk about that when we talk about.
Oh, okay.
Mhm. Okay, bubble heat. So you're going to do a bubble heat on all of your patients, whether they are vaginal delivery or cesarean delivery. So again, like your coat assessment, the bubble heat gives you a nice organized way to do your assessment. Make sure you don't leave anything out. You hit all the main points. It organizes your care, organizes your thinking, organizes your documentation. But even though I'm telling you you're going to do a bubble heat assessment, that doesn't mean you're not assessing the breath sounds, you're not assessing the neurological stuff, you're not assessing those other things. You are, okay? But this is like our focused postpartum assessment. Okay, so I gave you slides on each part of the bubble heat just so that you know everything that we're going through as we go through it. So the breast should be soft, non-tender. Plus the first couple of postpartum days, you always want to ask if they're breastfeeding or not. If there are any issues, make sure if she's breastfeeding that we're assessing for any signs of nipple trauma. And I'll talk more again about breastfeeding when we talk about newborn nutrition.
I'm sorry, Professor. You said that the breast should be soft and tender, but what happens if her milk came down already? Wouldn't they be firm?
Yeah, and painful.
I said postpartum day 1 and postpartum day 2. They should be soft and non-tender. The first 2 days, they should be soft. Thereafter, when the milk starts coming in more, then they become more firm.
Okay, so we're making okay.
The uterus we've talked about, assessing the relationship, the position in relationship to the umbilical line. We talked about that in terms of the involution into the pelvic cavity. We talked about it midline and the impact of the bladder. The consistency we've talked about, is it firm and contracted? Is it soft and boggy? Make sure you're assessing the fundus after she's voided. Again, clots can interfere with uterine contraction. 2 hands are always used. Now, if the uterus is not contracting, if it is not maintaining itself contracted, she may need oxytocin IV, an infusion of IV oxytocin, a continuous infusion to maintain that contraction. Most facilities now will give IV oxytocin after a delivery, whether vaginal or cesarean delivery. They will give it prophylactically. So whether she's contracting or not, she will still get an infusion of oxytocin, kind of to make sure that what should happen is happening. We'll talk a little bit more about what you're monitoring for and so on tomorrow.
Quick question.
Yes.
Can you define boggy? I'm not sure exactly what that
Boggy is
like.
soft, uncontracted, soft. It feels kind of mushy.
Okay, thanks.
So remember I said a firmly contracted uterus feels like a contracted bicep. It's a muscle, right? So if it's boggy, it feels kind of soft and it lacks, like a muscle that lacks tone. It doesn't have tone. It'll feel kind of mushy. Okay. Okay. 2 hands, I already spoke about that and why you're doing it that way. Bladder elimination, we've talked about this, you're assessing for distension. She may have diminished sensation. We talked about the ability to empty her bladder. Assessing, remember, you're always assessing for color, thinking in terms of hydration status. If there's any odor, displacement of the uterus, we talked about, assess the fundus after emptying the bladder. Again, making sure that she is voiding adequate amounts. Now, let's see. Okay, a few slides, I'll ask you a question. Bowel. So assess for bowel elimination, bowel sounds and bowel eliminations. Elimination assessed for hemorrhoids. So this left Sims position is the easiest position. I think you learned that in fundamentals to assess for hemorrhoids. Look here, we talked about already. So assessing the type, and again, in relationship to the date and time of delivery, so you know what is to be expected, and again, including that in your teaching. The amount we've talked about, the color we've talked about, any odor, malodorous is, your concern should be infection. Okay, so if you look back at your bubble heave, the E is for episiotomy. We don't do episiotomies as often as we used to do episiotomies, but the E is for episiotomy. Now, mentally, even though you know it's bubble heat, I want you to make the correlation that if the patient doesn't have a episiotomy, you are assessing for laceration, okay, if it's a vaginal delivery. So lacerations or episiotomy. If the patient is a cesarean, you should be replacing that E with, you know, mentally thinking about the patient's not going to have an episiotomy, but you could have an incision. So that in your mental list, as you're going through your list of assessments, that should be where you're inserting your assessment of the cesarean incision, okay? So if we have an incision, what I encourage you to do, and I will encourage you to commit the Rita scale to memory, because you will use it for every single incision that you encounter in your career. It gives you a nice, easy, organized way, again, to assess, document. You don't skip anything, okay? So you're looking at the incision. So whether it's an episiotomy, maybe it's a repaired laceration, maybe it's a cesarean incision. Is it red? Is there any redness? Is it erythematous? Is there any edema? Is it ecchymotic? So you all know what I'm saying when I talk about ecchymosis, right?
Yes.
Yes, okay. So is it ecchymotic? Is there any drainage or discharge? And of course, if there is, how much, what color, is it malodorous, that sort of thing. And then approximation. So how well approximated is the incision line? So well approximated. And this is where you're going to speak about staples, sutures, steri strips, whatever's holding it together or not, right? So whatever there is, dressing wise, holding that together. All right, so that's your Rita scale. Okay, so that's your bubble. So onto the he. Home and sign. So you covered this last semester, right? How to do home and sign, yes? Okay.
Yes.
Okay, so I'm not going to go over it again since you did that already. What I will stress for you is wherever you work, you always want to make sure you want to ask about the policy around home and sign before you do it. So even though we teach it, you want to check the policy. Now, you think about home and sign, what you're doing here when you dorsiflex the foot. Now, what if this patient, in fact, does have a DVT? What is the risk of having this patient dorsiflex her foot?
Dislodge anything in the blood vessels.
So would it be anything? What might be dislodged?
A clot, a blood clot?
So a small part, and that's all you need. It might not be the full thrombus. All you need is a small part. A small part of it may become dislodged and may travel to the lung. So there are many facilities that no longer do home ensign. It is against their policy. So if you as a nurse go there and you do home ensign, and this unfortunately happens, and the patient ends up with a pulmonary embolism, you won't have a leg to stand on, quite frankly, because that is not the policy. So before you do this, you need to find out what the policy is, right? Unfortunately, patients have died as a result of nurses doing home ensign with the best of intentions, trying to determine whether or not the patient has a DVT. And then the patient ends up with a pulmonary embolism and dies. All right, so we have to make sure we know what the policy is before we do it. So that's one thing. The other thing is I will always encourage you to have more than one way to assess everything. Okay, so kind of like you guys love, taking your notes on your computers and doing things on your computer. There's always more than one way to do things. You have to have more than one way to assess, right? So when we're assessing for DVT, we're assessing both calves. We're assessing both for warmth, for swelling. You might have to measure, you can measure the calves, okay? So look at the peripheral perfusion. So you have to use your other, again, expand your assessments. And do not rely just on one way, okay? All right, so while you're there, you're palpating pedal pulses, you're assessing for edema, and for our patients that we have neurological concerns, we might need to check deep tendon reflexes. So this patient, we're looking at pedal edema. I don't know how well you can see this patient has pitting. Here.
It goes down the finger.
Yeah. All right. So your priorities are preventing hemorrhage, preventing thrombophlebitis, preventing infection. Promote bladder elimination. Make sure you're providing for hydration and nutrition. Again, back to what we've talked about a few weeks ago. You need nutrition. You have to be well nourished to heal. All right. Comfort, hygiene, and always patient teaching, patient teaching, patient teaching. So promoting bladder elimination, that's pretty self-explanatory. What I wanted to ask, this is what I wanted to talk about, and then I have a question for you. So catheterization might be indicated if the patient is unable to void, if the amount voided is less than 150 mLs, and the bladder can still be palpated. So she's got some urinary retention. She's not able to empty her bladder. If the fundus is elevated or displaced and she's unable to void, this needs to be resolved. Or if she has a periurethral laceration. Again, we'll talk about specific types of lacerations tomorrow. So my question to you is this. You have a patient who is unable to void. What's the first thing you do? She's unable to void. You've palpated the bladder. It is full, but she's unable to void. What's the first thing you do? So give me some ideas in the chat box of what you're going to do. Okay, so I'm going to remind you, we always start non-invasive and work our way up to invasive, right? So the first thing is to, yes, take her to the bathroom. You see if she if she's able to respond to the auditory stimulation of turning on the faucet, of hearing water running. If that doesn't work, what's next?
Straight catheter.
Before you catheterize her, what's next? And so we're talking about a mobile patient, but remember, you might have a patient who has mobility issues, maybe aside from pregnancy, right? And so this is a patient that is unable to get up and walk around. So you always have to think of what you're going to do for your patient. Okay, so you run the water, she hears the water, nothing. Nope.
Drink a glass of water. No.
Then she drinks more water, that bladder's gonna be more full, right? Okay, so you could have her assume the position, so to speak,
Or
right?
warm,
That might help.
a warm pad or something. Usually, no.
So a warm pad where?
On the vulva.
So in the perineal area. So
Yeah.
what you can do is run warm water over the perineal area. Sometimes that will help. Sometimes running water over her hands will help. So you want to try to use what you can to stimulate the urge. So hearing the sound of water, feeling the sound of water on her hands, on her perineum. Usually you try those. Usually one of those will work. Now, let's say it doesn't, and you get to the point of, okay, we're going to have to catheterize this patient. So I'll make her an vaginal delivery. She's vaginal delivery. You're going to have to catheterize her. Are you going to insert a Foley catheter, which is indwelling that can remain for some time? Or are you going to straight catheterize her, which is a catheter that's not attached to the Foley bag? So you insert it, the urine comes out, you remove the catheter.
I will
Which
do that.
one would you opt for?
Straight.
Yeah, straight catheter too.
I didn't hear you. Say that again, Sensi.
What?
I didn't hear you.
Gusto muna.
The indwelling or the straight?
Straight.
Straight. So Andres, I think you're talking about a straight catheter, right? You're talking about a straight.
Yeah, correct.
Okay. So I want you all to think about this. What was your concern? What started this conversation? What was the concern? That the patient could not void, right? Okay. So when you catheterize her, you're catheterizing her through the urinary meatus, right?
Yes.
Which is
Stretched.
already traumatized.
Yes.
And so now you're catheterizing her. So when you straight catheter, you're inserting, withdrawing. What happens at 4 o'clock when she can't void again?
Oh, okay.
Yeah, that's what I thought. Because she has to keep waiting.
She has to what?
She has to keep waiting.
She has to keep voiding. Well, think about it. Remember what we said. Her body is now shedding all of that extracellular fluid. So she's going to be voiding every 3 hours, like significant amounts of urine. So I want you to think about what you're doing, right? So yes, I understand that you want to catheterize her, but I just want you to really think about how this might work for you and it might work against you, okay? Because if you straight cath her, that to some degree is traumatizing an already traumatized urinary meatus. And then now what happens 3 or 4 hours later when you need her to go again? You can't go in and say to her, we have to do that procedure again. You might not even be, first of all, she's not gonna like you, right? Let's just face it, she will not be happy with it. But that aside, you might not be able to do it because now the urinary meatus might be too edematous and now you can't get another catheter in. So I want you to start to think about how this plays out on a practical level, okay? These are not so great situations that you will encounter.
Professor, how long you leave Foley catheter in this situation when you want a mom to be able to feel the sensation, right? To be able to void and urinate by herself. I mean,
Right,
how
and
long do you
and that's where it
expect-
gets tricky. That's where it gets tricky, honestly. I mean, you might have to put in now, see, the advantage to putting in the indwelling, the Foley catheter with the bag, is even if you decide to take it out 10 minutes later, but you've given yourself that option, right? So sometimes you put it in and she might only need it for like 6 hours or 8 hours,
Exactly.
right? She might not need it for days. She might need it short term, but still it gets you kind of over that hump. Because remember, you've got to keep that bladder empty, because if the bladder's not empty, the uterus is not going to involute, you're going to increase your risk of
Okay.
hemorrhage,
Yeah.
right?
And
So
probably,
you have to think about how all these pieces fit together.
okay, so
Question.
probably
What are the indications that she's good to go? Like we can go ahead and remove that. Like what am I
That's,
looking?
and that's the thing, to some degree, you never, you have to go by feel, really, how it's, give the urinary meatus some hours to
adjust.
heal, to heal. You might have to put some cold, a cold compress on there for a few hours and so on. Yeah,
Professor,
just gives it time, give the body time.
the epidural can slow the process or not?
Slow what
epidural-
process?
The voiding, like the sensation or not?
Yes and no, but we'll talk more about that when we get to
Okay.
the epidural. Yes and no, but that is going to happen more before the delivery, because now remember, we're talking postpartum. The epidurals,
Okay.
at this point, the epidural's already out.
Oh, okay.
I'm
Yeah.
sorry, Professor.
Yeah.
So if we want her to void and we're going to insert this Foley catheter, she's only in the hospital for what is it, 2 days if she does a vaginal regular delivery.
Mhm.
So before she gets discharged, we want to make sure she's able to go. So if she's having trouble right away, I mean, wouldn't we want to insert this Foley earlier so this way she can go and this way we can begin?
Well, that's what I was saying. I mean, we're talking about fairly early in the process, right? And so remember, I said you might have to leave it in for 6 or 8 hours. But if she's there for 48 hours, that leaves you enough time to ensure that she's voiding on her own before you discharge her,
Okay, yeah.
right?
Yeah, because
Yeah, it will give you enough time. It will give you enough time. And if not, because you might have, things happen. You might have a situation where, a mom is having prolonged problems, that will extend her stay, right? So the 48 hours is for the delivery, but then she needs to extend the stay to resolve whatever this bladder issue is. Okay, so the point is, I want you to start really thinking about how this plays out.
Delivery, the if there's no anesthetic in the body, that means it shouldn't
So
affect.
chances are, if she had an epidural or a spinal or CSE, there won't be enough. Usually there isn't that much that's going to cause this on its own,
Okay.
okay? Not for a vaginal delivery, all right? It's a little bit different if it's a cesarean delivery, because remember, you really need anesthetic for a cesarean delivery. This is a surgical procedure, so it's going to be more intense, right? As opposed to a vaginal delivery, you're looking at more analgesia than anesthetic, right? You're looking at more pain management than loss of sensation. Okay.
Okay. Thank you.
All right. So as I mentioned, you want her to hydrate. So encourage at least 2.5 liters of fluid per day. Whatever, keep it all culturally appropriate, whatever she likes to drink. The important thing is to keep her well hydrated. She's not able to tolerate PO fluids for whatever reason. she might still need IV fluids, but usually within the first few hours postpartum, most moms, we can take out their IVs if they are taking in enough fluids and voiding adequately. So we want to make sure that she's well nourished. She's getting in her vitamins, her minerals, her iron, because again, the body has a long, several weeks of healing to go through. So we want to make sure that she's well nourished. If she's not well nourished, she's not going to heal. Okay. All right. So comfort measures, ice packs I've talked about in the first cool in the first 24 hours, ice packs or cool sitz baths first 24 hours, warmth thereafter. Perineal care I mentioned already. Topical medications. Some providers, some facilities will use Dermoplast, which is a lidocaine, an aerosol lidocaine preparation. So it diminishes some of the pain and discomfort to the perineal area. So that can be sprayed on. I don't think I didn't put it, I don't think I put it on your med list. I can't remember, but I'll post the med guide for it, just so that you have it. And then analgesics. We might use, a lot of times it's ibuprofen. It's very commonly ordered after an SVD. A cesarean delivery, she might have an order for ibuprofen, or she might have an order for ibuprofen and Percocet, or oh, my brain just went blank. There's one more that I can't remember that I will tell you tomorrow when we talk about pain management. All right. So we may have time. Okay. So those are your NSVDs. Everything that I said still applies to your C-section patients, in addition to what you learned last semester about post-op care. So I don't remember what chapter this is in your Potter and Perry, but remember I told you this on day one, that you would have to review that post-op care. I do expect you to know that. So your cesarean patient is a postpartum patient. She is also a post-op patient. So all those general principles that you learned will apply to her. All right, so same picture that I showed you last week. So remember, you're going to use your RITA scale to write your assessment of the incision. So redness, edema, ecchymosis, discharge or drainage, approximation. And remember, when you're writing your note, like for this one, the approximation, you would include the fact that she has staples and that the staples are in place and that they are intact, right? They're not like, hanging out, just being dislodged, right? They're there. You would say how many they are and that they are intact, in place securely, okay? All right. What specifically are some of the things that you would have in mind as far as your nursing care, some of the nursing care assessments, measures, activities, some of the things that you would do for a cesarean patient, post-cesarean patient, postpartum cesarean patient?
A concern would be at the lung collapse. So giving her the.
I didn't hear what you said.
Well, a concern for a patient who had a C-section would be her giving her the, what is it called, the sphygmometer, so she could breathe through, so to prevent lung collapse.
So incentive spirometry, is that what you're talking about?
Mm-hmm.
Okay.
Ambulation.
Say that again, Andres.
Ambulation.
Ambulation, so absolutely getting her up and walking.
If she's bedridden, the movements and making sure she's dry and all that.
Mhm. So I have a question, but I'm going to wait until, excuse me, it's part of your bubble heat, right?
Oh, bubble heat, sorry.
Okay, so let me ask you this. I see, oh, you didn't put in, okay. So we have a C-section patient. So let's say she's doing well, she's progressing well. Remember, she had a Foley placed to go to surgery.
Mhm.
So you want to get her, she's at a point, otherwise everything is nice and stable. You want to get her up and walking. So I'm going to ask you all to put in the chat box what you're going to do. Are you going to get her up and walking first, or are you going to remove her Foley?
Wait, you said is walking first, or you said what is?
This is a post C-section patient. Everything is stable. Everything is stable. She's at the point where she needs to get up and start walking. Are you going to get her up and walking first? Or are you going to remove her Foley first? So you've done the sit-up, you've done the, dangle, but, so my question is, do you get her up and walking first? Or do you remove the Foley first? And I will remind you, what I told you on the first day, you give me an answer, you gotta have a rationale, right? So think about it, and then I'm going to ask you in just 1 minute for your. Okay, so I see lots of walking. So Cynthia, I'm just gonna pick people arbitrarily. Cynthia, why walk first? Why are you walking her first? If I can even find you.
Because you want to get her moving,
Mm-hmm.
and then remove the Foley after. So I'm not sure.
That's okay. That's okay. Let's see, who haven't I heard from? So Aminata, you're saying remove the Foley first?
Yes.
Why? Okay, so because she's stable. Say a little bit more about that. Can you say a little bit more about that? No. All right. Tenzin, you're saying the Foley first.
Yes.
Because if she walks with, so you're thinking it might cause trauma to the urinary meatus? Is that what you're thinking? Okay. All right. So what about some of the others of you here? Only a few of you have responded.
Oh, it's my internet.
Okay.
Hear you.
So I was asking you, you said remove the Foley first. No, now you're frozen again. That's okay. All right, so what do the rest of you think? Or you don't think?
Just saying remove it because if she's stable, it's safer to have it out. The ambulation will help things come out. And it's if she's walking in the hallways, does she really want to be carrying a bag of pee around? You know, she might be embarrassed by it.
So she might be, yeah. But so going back to, let me just back to what Tenson said, it's more than likely is not going to cause trauma to the urinary meatus, because this is a section patient, right? So I want you to remember with Foley's, you might have a patient that has bladder surgery, kidney surgery, that might go home with a Foley. She might go home with a Foley, all right? So they can stay in for quite some time and not cause, you know, great discomfort. They're in, body kind of acclimates. Now, here's my question to those of you who said remove the Foley first. What if you remove the Foley? She's in bed, you remove the Foley, and then she can't walk for whatever reason. She's too weak, she's too lightheaded, she's too whatever, she can't walk to the bathroom. You know what that means for the rest of your shift, right?
Yeah.
Getting friendly with that bedpan, which I'm sure you don't want to be bothered with, right? But listen, I mean, I want you to think about what might not work, what might work and what might not work, okay? So if you take the Foley out first, you have to recognize the fact that this patient might not be able to walk back and forth to the bathroom every 2 or 3 hours, because remember, we want her voided, okay? So there's that. Now, on the other hand, if you walk her, you can walk her with the Foley. Doesn't mean that you have to do that every time. You can just make sure that she's able to make, you know, make one lap or whatever, and then remove it. So the reason that I bring that up again is I want you to start to think about how all of this will actually play out and the pieces that you need to consider. The pieces that you need to consider, okay? Now, there is no hard and fast rule. There is no right or wrong way to do this. I've worked on units, postpartum units, that there are nurses who will always walk the patients before they remove the Foley, and there are nurses that will always take that chance, take it out, and cross their fingers and hope it works. And I've seen it work and I've seen it not work, all right? But again, you have to really do a real full assessment of your patient if you're going to take that Foley out first, and recognize the fact that there is the possibility that this patient may not be able to do the walking you need her to do.
Professor, the fact that the patient personal experience, I felt at one point that I needed to void, I mean, and that the Foley prevented me to have my, you say, the control, the voluntary control. So it bothered me.
Not that there's control. So remember something, the urge to void is connected to the stretch of tissues, right?
Yes, to the bladder, yeah.
Of the bladders, the stretching. That is what gives you the neurological urge to void. But when the Foley is in place, the bladder doesn't fill, so there's no stretch. So it's not that she doesn't have the urge or that she can't. It's just not stimulated.
Okay.
Because the Foley is continuously draining the urine. It just never, we just never get to that point. But my point is that I want you to start to think about these things, okay? And so when I ask you questions, and you will see, you know, on my exam questions tend to be kind of scenario based. And so when I put you in a situation, I want you to start to think about all of these pieces, okay? All right? And so as we're going forward and talking about cases, I really want you to start to pull all of these pieces together, okay? All right.
So quick question. So just to summarize, the bubble head, the
bubble heat?
Yes.
Mm-hmm.
The bubble heat we do on all the patients.
I think I warned you on the first day, this is like a whole nother language, right?
Mhm.
Go
Yeah.
ahead.
So we do that one on all the patients, but then we only use the Rita when they're cut.
No. No cutting. Remember? No
Well, then
cutting.
episiotomy or the C-section.
Incision.
So episiotomy, lacerations, or cesarean incision. You'll use the Rita scale. So an episiotomy is a surgical incision. The laceration is the perineal tissues tear. All right, we're going to talk more about that tomorrow, but if there's any break in tissues, then you're using your Rita scale. Yes.
Yes, okay.
Okay. And remember, a post-op cesarean patient is a post-op patient, so I expect you to do a full post-op assessment. Okay, so you to tell me at least one complication, that you are going to monitor your post C-section patient for, at least one complication.
For each one, or just pick one and put.
For each one, for each body system. And I lumped neurological and musculoskeletal together, so you can just give me one for those two systems. But you all know this. It's not that you don't know it. You know this. Most of this you know from fundamentals. I've only mentioned a few things. So I want you to make a list. So list the systems and at least one complication per system. So again, this is any C-section patient. I'm not saying someone that has any history. So you should all have at least one thing for every body system. Now, remember, I didn't say that this was a complicated case. Just a patient who needed cesarean delivery. So I see some systems being addressed. I don't see every system being addressed. So I hope that what you're writing down is more detailed than what I'm seeing in the chat box. All right, so give me some complications for neurological musculoskeletal. I see a lot of respiratory here. I only see two people telling me things about well, that's cardiovascular. I'm not seeing stuff about neurological musculoskeletal. So neurological, musculoskeletal, only that. All right, so Andres, why might she have a headache?
Like you stated before, the epidural has been punctured.
So a postural, so it might be a postural headache, yes. Might be a postural headache. What else? Musculoskeletal. This is a patient that is post-anesthesia. We just talked about getting this patient up and walking. So what is your main concern there?
Fall.
Absolutely, the risk for falls, right? And that factors into your unsteady gait, right? It doesn't, she might not have an inability to walk, but a risk, right? Okay, so what are you going to do before you get this patient who is has had anesthesia, before you get her up and walking?
We'll ask her questions. How is she feeling? Is she feeling dizzy? Is she able to walk? I will assess her blood pressure as well.
So I tell you, I feel great and my blood pressure is fine. So you get me up?
No. Well, if you're laying down slowly, I would bring up the bed, and I would just bring up the bed and try to analyze you, see your facial expressions.
So
And
I look just as happy. You're gonna walk me. I'm gonna be walking. I just had a baby. I'm happy. I'm ecstatic. Doesn't mean my legs are not gonna turn into spaghetti once you get me up, right? Before you even move the head of the bed. This is a patient that has been anesthetized. You need to make sure that the patient has some sensation in the lower extremities, right? You need to feel my legs, feel my feet. I should be able to tell you, you just touched my left foot. You just touched my right calf. Because if I don't have sensation, you shouldn't even dangle me, honestly, if I don't have sensation, right? Because if you even try to stand me up, I'm just gonna buckle. I'm just gonna buckle. So you wanna make sure that before you even get that far, even before you do that, right? Even before you sit the patient up, just as you're standing there talking to you're standing at the bedside, you can touch the patient's leg and say, can you feel that, right? But you wanna make sure the patient has sensation, okay? You wanna make sure the patient has sensation. You wanna make sure that if you put your hand up, the patient can push her foot against your hand. So you know that she's got some strength before she puts her body weight on those lower extremities, all right? I want you guys to go back for unit 2. I know I'm not saying do it tonight, because I kind of have an idea what you might be doing this evening. But after the exam, I want you to review the post-op stuff, okay? Because it really is very, very important. Not just for today, not just for this class, but you're gonna have post-op patients next semester and going forward. I want you to really get that post-op stuff into your DNA, okay? All right, so neuromuscular, remember all of those mobility issues, risk for falls. Neurologically, again, you want, if she's had epidural spinal CSE, your concern should be about the headaches. Remember that she is a postpartum patient and might be developing late preeclampsia. So you're concerned about any sort of headache, Respiratory, I saw atelectasis, I saw pneumonia. Those are going to be your main concerns. Cardiovascular, I saw thrombophlebitis. Remember that hemorrhage is a cardiovascular concern. Hemorrhage is always a concern with any post-op patient. GI. What's your concern, GI? I don't remember seeing this one.
Reduce the bowel mobility.
No, I want two words that you learned in fundamentals. Talk to me about GI. And constipation is not one of them.
Bowel impaction.
Not one of them.
Nausea, vomit.
Something with ileo. oh my God.
Okay,
Paralytic ilio.
Tap your colleagues there, see if they can help you with that.
Paralytic ileus.
Paralytic ileus, you gotta know that. Excuse me one second. Okay. It's just checking. I thought I was alone, but I'm not. Okay. Paralytic ileus. Make sure you review that. It's in that chapter, post-op, okay? Genital urinary, we talked about urinary retention already. There's always the risk that if you have a patient that's had a indwelling Foley catheter, that it's there for a long time, or even if it's not there for a long time, if poor technique is used, there's always the risk of a UTI. Integumentary, remember, if this patient has had any sort of incision, we have broken the integrity of the largest organ of the body, right? So anytime we impair the skin integrity, there are risks for infection, risks of dehiscence, and so on. Immunologic, always the risk of infection. Now, this is a C-section patient. So what is your psychosocial concern?
If it's not planned, she's not gonna be accepted.
Well, let's say it's planned.
Oh, okay.
It's planned. It's a CPD.
Support.
This mom had CPD, so she knew from quite some time ago that she was going to be a section.
So family support, if she has someone who can help her with a baby.
So, okay, but she's post-op now. She is so don't go all the way to depression. Don't go all the way to depression yet. Remember that this is a mom who just had a baby. She's had anesthesia. Is she going to really be able to connect and hold her baby and breastfeed her baby and do all those things with her baby that she might have planned to do? For the first couple of hours, she still has anesthesia on board, right? You're not going to necessarily give her a baby and turn your back, right? So I want you to remember what I keep saying to you about safety, 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 right? So you're not necessarily going to do that. So there's going to be a little bit of a delay to the connection with her baby, all right? So granted, she'll see the baby and all of that, but it's going to be a little bit different, all right, for her. So again, I want you to start thinking about all these little things and how it impacts on your care, how you do your care and how you interact with your patients, how you're supporting them, what you might be saying to the family to help support the patient, okay? You certainly can bring the baby to her, yes. But again, it's going to be different than if this mom is fully awake and doesn't have any anesthesia on board for her to hold and be with this baby, okay? All right, so what are some of our criteria for discharge? Do we just say, okay, 48 hours, insurance has stopped, you gotta go. Pack up get your stuff together, off you go. 72 hours.
Take your baby. Take your baby and
somebody in the OR that needs to get in this bed. Come on, come on. So, this is important. because you very often will be, well, not you will be the reason, you won't be the reason, but you will, if there is a reason that this patient should not be discharged, you got to recognize that and bring that to the provider's attention. You don't want to send a patient home who really needs to be in the hospital. Maybe they need 6 hours, maybe they need another day, okay? So what are some of the things that you are assessing for? So remember, the patient absolutely has to be hemodynamically stable. No signs, symptoms, hints, clues, idea. She's not hemorrhaging. You cannot send her home if you have any possible concern that this patient's going to hemorrhage or is hemorrhaging, right? So you have to be sure that she's hemodynamic, at the very least, that she's hemodynamically stable. Remember that she's a postpartum patient. That was one of your main risks. You've done your DVT assessments, no risks there. Because remember, what starts as a DVT can become a pulmonary embolism, is not going to, well, tends not to end well, okay? So, hemodynamically stable, stable vital signs, uterus is involuting the way it should, she's able to void, she's stooling, she's connecting well with this baby, no psychosocial concerns, okay? The lochia is not excessive. Mentally go through your bubble He and make sure she's stable as far as your bubble He. If this is a C-section patient, your incision is good, your post-op checklist, your mental post-op checklist is good, okay? Oh, I just realized something. I went through the bubble He, but when I did, I don't think I had a slide. That's why I skipped it. So emotional, oh, I know why. Emotional status kind of runs into the next. That's why I didn't. Okay. All right, so we want to make sure that she meets the criteria for discharge. She knows who to call if she has a question, if anything is going wrong, if she has any questions about anything. We want to make sure she has a medical home, so she knows who she's either calling for an appointment or when her appointment is to come back, who she's seeing, what she needs to do as an outpatient, okay? And then the psychosocial stuff, I'll roll over to the next. Okay, so questions. Yeah, I'm just going to go over one slide because I know that you guys are just like, everybody needs a nap so that you can finish studying and getting ready for tomorrow. I get it. I just want to say this, show you this one slide because I didn't really speak a lot about the emotional status in your bubble He. So this would be basically what you're doing. Evaluate the mom's emotional status. Is she dependent, independent? Is she happy? Is she sad? Does she have a support system? Pay attention to those nonverbal cues, okay? Crying, a little bit of emotional ability is okay initially, but you don't want, huge swings in mood. And we will talk about the difference between baby blues and postpartum depression. We'll talk about that tomorrow, okay? But these are like the basics of that last E in your bubble He, which is the emotional status, okay? You're gonna pay attention to what's going on with your mom and make sure that she's got some support of whatever type, Family is what your patients tell that you just wanna make sure she's got some support, All right. Okay, so I'm going to end there. I know it's a little early, but I know it's a lot of information. We have a date tomorrow. So I know I want to give you a chance to get a break and eat some lunch and then get back to reviewing. Tomorrow we will be in N451. So please do not come up here because there will be nobody here. Okay, N451. Please remember, so you know the drill, you have to have your mask and to do your whatever that thing is, the Everbridge or whoever it is. You'll remember to do that. Make sure you bring your pencils. I have the calculators for you, so you don't need that.
What is the
We'll take
topic
a short
tomorrow?
break and then we'll have a little class, some class time after. You had a question, Fred?
Yeah, what is the subject for tomorrow? So make sure I have that all ready in my iPad.
What are we talking about? What is the
Subject for class.
the subject? Ooh, I'm gonna open it after. I just realized I didn't open it. I actually, that one I did intentionally. I didn't want to like overwhelm you.
Too late.
We're doing, we'll finish this, the psychosocial, and we will talk about, let me see which one I want to, we'll do procedures. So we'll finish the psychosocial and we'll do procedures.
And you're opening up that later today.
Yeah, I'll do that. I'll make it available after class.
Thank you.
Okay. Questions? Okay. Class time. So we'll have the exam, we'll take a little break, and then we'll have class for the rest of the time.
Okay.
Professor, are we going to be using 2 rooms again for the lecture?
We're in N451 tomorrow for the whole time,
Okay.
for the entire time. Much easier on me. It'll be easier on you too, but definitely easier on me. All right. All right, so I'm going to leave the Zoom open for a few minutes if there are questions. Otherwise, I'll let the rest of you go, and I will see you all tomorrow. Okay?
9 a.m., right?
Thank you.
9 a.m., yes. See you
Okay,
later. See you
thank
tomorrow.
you.
Thank you, Professor.
Bye, everybody.
Everybody.
Bye, Professor.
Bye. See you tomorrow.
Bye, Professor.
Bye. See you tomorrow.
Professor? Can you hear me, Professor?
Yes, I can.
I would like to ask, like, I'm getting confused with the delivery, right? If the mother had already 2 child and she's under a delivery, she will be probably having a shorter labor as compared to the a mother who is having her first baby, right?
She will be what? I didn't hear the first part. So this is her second delivery, her second
Yeah.
pregnancy? Mhm.
She's in her second pregnancy, right? And she will be having a shorter labor period as compared to the
first one.
mother who's first pregnancy.
Correct.
Okay. And when I went to the PowerPoint, I saw like for the first pregnant women, right? They have like thinner cervix as compared to the multi gestation mom. The mom has
Because with
thicker.
like every delivery, there's almost like, it's almost like a little scar tissue. So it makes the cervix a little bit thicker.
Even though they have like the scar tissue, they will have a shorter period of labor, right? The mother with the
The multiparous, right? They have a shorter labor, but although the cervix is a little bit thicker from the scar
Mhm.
tissue, but it
Okay.
does dilate faster. It's almost like the body knows what to do, so it just kind of does it faster.
Okay, and
Kind
Professor,
of
we
like
don't have to know about the duration of labor, right, for the
No, I'm
second.
not. I won't ask you that.
Okay, sure. Thank you so much, Professor.
Too
See you
much.
tomorrow.
Professor, when the uterus, when the bladder pushes the uterus out of place when it's full,
I'm sorry. The bladder, it pushes the uterus up.
is that, does that need to be surgically corrected? Is that why that's such an issue? Because it's
No.
a
So so whether if she's in labor, the full bladder will push the uterus up, which will prevent fetal descent. If she's postpartum, the full bladder will push the uterus up, preventing it from descending the way you want it to, right? So it doesn't have to be surgically corrected. What we need is to get that bladder empty. So whether getting her to void, getting her into the bathroom, running the water and all of that, or catheterizing her. What you need to do is get that bladder empty. Does that answer your question?
Okay, so I guess, I mean, I guess just what would happen if you just, you know, she didn't void for a day? Well,
No,
then
you-
her bladder would explode, right? Or the urine
Essentially, yes, but
would get back.
yeah, no, you have to catheterize. You have to catheterize. Yeah. If the mom is unable to, whether because of lack of sensation and whatever's going on, she has to be catheterized. Mhm.
Okay, and then the
Bladder has
timing,
to be empty.
so the timing on that is 3 hours, correct? It's
The
like
timing on what?
like when she has to empty. But
So
like after the end of the birth,
pre-
it has to be 3 hours.
If she is in labor, you're checking every 2 hours. If she's postpartum, every 2 to 3 hours. You want that bladder to be empty emptied every 2 to 3 hours.
Okay, thank you.
Yeah. Other question?
Professor, I have a question.
Yeah.
If it's a gravid client, right?
Mhm.
And if she's on second stage, and if she's feeling to urge, right, to push the baby, and I mean, I remember in the class you say in New York and in United States we prefer lithotomy, no?
We prefer, I'm sorry, say that again.
In United States, we prefer lithotomy, right? The position.
Yes. Mm-hmm.
But according to the scenario I described, I found in one of the source that said like squatting. And anatomically that makes sense, because when they are in squat position and the mom is the first time, because she's gravid, right? Since the gravity and everything, it is anatomically correct. But if it's a question comes like that, we're supposed to think according to United States or according to anatomically what is correct.
Well, here's the thing. The squatting position, whether she's a prima gravida or not, if you think about it, works. Gravity is going to work in her favor, right? To help with the fetal descent and expulsion of the fetus. So in many other countries, that is more accommodated. It's just here, we tend to do this lithotomy position, which, I mean, obviously moms deliver. It just doesn't, it doesn't factor as well into the natural process of what's happening. So it happens, but it just doesn't factor in as well. But I mean, as far as I don't want you to worry about me asking you a question like that. I'm not going to ask, but I think it's important for you to know that because we practice a certain way here in America doesn't necessarily mean that it's the best way, right? There are alternate ways and other places do things differently.
So if it's in NCLEX, we're going to think anatomically which is more correct? If it's not about the
Um,
BMCC, what do you think? We can
So
do the anatomy
when
too?
NCLEX, they probably won't ask you something like that. But I think it's just important for you to understand the concept.
And one more question, if I'm not wrong, if a patient's rupture of the membrane, right? If the membrane is ruptured, the first nursing intervention we're gonna do is we're gonna assess the fetal heart rate. Then we're gonna
Correct.
check the code, which is color, order, the amount, and then
And
we're gonna
document
put
the time.
the mom as a lateral recombinant for the well perfusion, right?
So the first thing is the fetal heart rate. We're going to talk a little bit more about that tomorrow. Fetal heart rate first, then your
Then
coat
the code,
assessment.
and then the side lateral.
Not necessarily, and depending on what's going on, she might be able to sit up. She might be able to still walk. It really depends on what else is going on. How dilated is she? How effaced is she? You know what I mean? It depends on
Based
what
on the
else.
scenario. And if your mom is I'm sorry, I keep asking. The last one, I guess. If a mom is postpartum, I mean, after the baby is delivered, right? So is the next 5 or 6 hours, and the mom wants to go to the restroom. So as a nurse, what's the best thing to do? So let her sit first to understand, in order to prevent the hypotension, and assist her to go to the restroom, or let her stand first to understand that she can carry her weight or no. So the answer
So
was
it's going to be this is going to be pretty much what you did in fundamentals. You know, sit her up, let her dangle, stand her, let her stand,
to
then
see
take a few steps, and then yeah.
Oh, but I never do the help first. Like, don't go with the answer like, oh, help her, assist her to go to the restroom. No, don't go for that, right? Because my as a nurse in real life, I was thinking, if I want to see that she can stand, the answer was let her stand to see that she can carry her weight, something like that. So I was thinking, if I let her do that, because it's just 5 hours, she just had the baby. What if she was trying and I was trying to observe, and by that time she fall, and I'm gonna be in trouble, because that's not what's supposed to happen in front of me.
So it all boils down to, again, your assessments and, you know, the step by step. Now, let me just say it's 5 hours, but you have some moms who are up and walking 2 hours after.
Okay.
Yeah, so don't get too caught up in the time. Some moms, you know, they're fine, but if they feel like they feel like they want to get up, they're alert, they're active, you do your full assessment, you let them sit, dangle, stand, they seem good, take a few steps. You know, you have to do it in stages, slowly. But if she's walking,
I never know that after 2 hours they can stand up. I don't know.
Yeah.
Okay.
Yeah, I've seen plenty of moms 2 hours later, they're like all over the place, you know? Yeah.
That's good then. Because I was stuck with the hours. When it says 5 hours, I thought like, oh no, I supposed to assist her. And the answer was no, let her stand and to see how she carry her weight. So, okay. Now
Yeah. The thing is to make sure that you do you're assisting her that first. Yeah, you're assessing and assisting her. And then if she's okay, she can walk. Yeah.
And the maneuver, the maneuver you shows us the video, right? The Leo Pulse maneuver. Is there any precise step that you have to assess or it gonna according to the baby's position? Because I saw pictures, and in the picture it was the baby's head was close to the pelvis, which means the baby was longitudinal and the head was down, right? Which means the occipital, right? And that says is the third step. That's the third maneuver. So you get my question, no?
The thing is, though, I don't want you to worry about so much about which maneuver is with, like the first one, the second one, the third one, the fourth one. What I want you to remember is you need to, why you're doing it, you're doing it to assess the fetal position.
Yeah.
So that you know where to assess the heart rate over the fetal back. That is the main thing that I want you to remember, okay?
So if the baby's head is on the xiphoid, which means if the baby is on the longitudinal, but on a sacrum position, right?
Mm-hmm.
So I'm gonna place the tocodusers on the top of the baby's head, right?
No, the tocotransducer will always, yes, the tocotransducer, yes, will always go on the fundus, right? The thickest
Yeah.
part of the uterus, because the tocotransducer is picking up the contractions.
Yes.
But the fetal heart Doppler, that is going to move depending on the position of the baby.
And it's gonna be on the baby's back, right?
Correct. So
Okay,
you have to figure out where is the baby, which way is the baby facing? Is the back here? Is the back there? Where is the back?
So the
So then you know which-
tocoducer, that's gonna be always universal. It's gonna be always on the fundus, on the top.
because
But-
that is for contractions. The contractions
and
are
that's what-
always going to come from the fundus.
Yeah, and it always relates with the mom. But the baby's one, it's gonna relate with the baby's
It's gonna-
position.
Correct.
Thank you so much. Thank you so much.
You're
I
welcome.
kind of get the whole idea now. Thank
Okay.
you.
You're welcome.
Bye bye, Professor. See you tomorrow.
Okay, see you tomorrow. Andres, did you need to speak to me? Did you have a chance to see my email?
Yeah, I saw the email, Professor. So I'm gonna reply right back to you.
Okay, all right. It's just that I need to get back to the professor. You know, the choice is it's
Okay. We'll do. As soon as we
oh, okay. Okay.